Welcome back to another episode of Seeing Without Eyes. I'm Kenneth Pua, your host, and I've got Angela Peters, who's producing the show. Now, today we're going to talk about blindness, and we're going to focus on retinal dystrophy. There is so much going on in the field of science, hopefully with great amount of hope and anticipation. We're looking for prevention, we're looking for treatment, we're looking for cures. But there's so much in there and so much to process and so much to digest. It's a whole world of scientific research and discovery. To help us today, I've got Professor Fred Chen from the Lion's Eye Institute right here in Perth. And we also have Renee Loftus, who works with Retina Australia, WA. Well, welcome to the show, and thank you for being here today.
Thank you.
Now, Professor Chen, can you tell us a little bit about your background and what led you into this field of work?
I started training in ophthalmology back in early 2000s, and after general training in eye surgery, I then went to London to spend 4.5 years there, do further training in retina specifically, medical and surgical retina. There I came across techniques of cell transplantation and bionic eye implants. So I did a PhD at the University College of London, specifically looking at cell transplantation to treat various forms of retinal degeneration, including macular dystrophy and macular degeneration. But at the same time, I also was privileged to be involved in the Argus 2 bionic eye implant program, in which we implanted retinal prosthesis in 7 patients. Following that, I returned to Perth at the end of 2010, and my interest was really focused on the most common cause of blindness, which is still age-related macular degeneration, particularly the geographic atrophy form. Inherited retinal disease wasn't my main focus at the time, but over the last 5 years, I started to realize it's a bigger problem than we realized, because many patients who were referred for age-related macular degeneration treatment trials, in fact, had inherited retinal disease. And so that's how my interest in this particular disease started.
Now, for the benefit of our listeners, in layman's terms, what is retinal dystrophy, and how many types of dystrophies are there?
So retinal dystrophy, or another word is inherited retinal dystrophy, is in fact inherited disease. So it's a genetic condition in which patients or affected individuals manifest degeneration of cells within the retina, which is the light sensing layer inside the eye.
Is that the same thing as cones and rods?
That's part of it, yes.
That's part of it, okay.
Yeah. It is uncommon. However, about 1 in 3,000 individuals have it. And of all the people who are registered blind, say in WA, of which there are about 200 to 300 each year, based on the data published previously, there will be up to 10 individuals among those people who have this condition as the cause of their blindness. If you look at the working age population between, say, 15 and 65, this particular disease will contribute to 20 to 30% of the blind registration, which is by far the biggest group. This disease is progressive. Majority of time is very slowly progressive, so it's uncommon to see it rapidly deteriorating. There are many forms of inherited retinal dystrophy. Some forms preferentially affect central vision, and others preferentially affect night and peripheral vision. We call these diseases by how they affect the retina, whether central or peripheral. So, for example, terms like macular dystrophy, retinitis pigmentosa have been used for many decades. But more recently, we now classify these diseases based on the genes which cause them. Now, there are probably around 300 different genes that can cause this whole family of disease, which can manifest in many different ways, right from birth to someone who's 80 years old and been diagnosed with inherited retinal disease.
So we're talking about a profile which is not really uniform, is it?
Correct. So there's a vast variety of manifestation. That's one of the difficulties in studying this disease, because many people have not been identified.
Where does it come from? What are the causes of retinal dystrophy or inherited retinal dystrophy?
So take for example, Stargardt's disease, probably the most well-defined condition. It's caused by ABCA4 mutation. ABCA4 is a gene that encodes for a protein which is required for the coenzyme rod to function. It gets rid of the waste products within those cells. So if that gene is not working, then the waste product builds up, which then become toxic to the cells, and the cell dies. So that's just one example. And in this particular disease, in Stargardt's, the individual will have two mutations on the gene. One in the gene that he or she has inherited from the mother, and the other one inherited from the father. So neither parents will be affected by the condition because they only got one mutation each, but the child or the person affected will have two mutations.
So if we go back further to the parents, one from the father and one from the mother, take us back further. Where does this gene originate?
Good question. We don't know where mutations come from, and mutation can occur randomly. So it's possible that neither parents will have any family history of the disease. As a result of random mutation, they've now carries the mutation, and just so happened that the two met and have a child, and the child, for each child from these pair of parents, there's a 1 in 4 chance that they could have inherited the condition.
Right. So the gene may exist or be held in a person's body, but it doesn't necessarily mean that the person will show signs of it. Because take my family, for instance. I'm the only one who's actually presented with RP. None of my siblings actually show any form of retinal dystrophy as far as we know. Does it occur randomly in the person as well? Could someone be a healthy carrier, if you will, for that condition?
That's probably the most likely scenario, that both parents are carriers of the mutation, and because the other copy of the gene is working fine, they don't manifest the condition. There's a 1 in 4 chance that each child can carry both mutations from the parents. So that's how this manifests in a sporadic setting.
I see. Now, you said that there seems to be a trend. Is it a rising trend of people presenting with retinal dystrophy?
There has been a trend recognized in the UK based on a study that looked at differences in prevalence over a 10-year period. There was reduction in blindness due to diabetes, whereas the blindness due to inherited dystrophy has increased significantly. And I think that's partly because of recognition, so people are getting diagnosed now, whereas before they were not recognized. And I think in conjunction, there's probably better treatment of diabetes and screening of diabetic retinopathy, leading to a reduction in prevalence of blindness due to that disease.
Are there any conditions in the external environment or in one's lifestyle that would make one more susceptible to retinal dystrophy?
There's a large variation in the way retinal dystrophy manifests, even within the same family. So, for example, there may be 3 generations, 4 generations, they might all have the same gene, but the way it manifests in different generations may be very different. And so we think there's either other genes that are involved in modifying how this mutation is manifesting, or there are environmental factors, as you suggested. These is kind of thing that scientists are working out at the moment.
If you've just joined us, we're speaking to Professor Fred Chen of the Lions Eye Institute and Renee Loftus of Retina Australia, WA. And we're coming to you from our studios in Perth, Western Australia. This is Vision Australia Radio Perth. So someone comes in and he's diagnosed or she's diagnosed with retinal dystrophy. What are the external signs, and what is there a difference in the way it affects different people?
Yes, so there are people who present very early on. Sometimes babies will be born and they have very poor vision, and the first thing they manifest is wobbly eyes. So if you see a baby with rapid moving eye, horizontally or vertically, you have to suspect there may be some problem with the vision, and these can get picked up very early on by pediatric ophthalmologist. Then as the infant matures and through childhood, sometimes children are picked up to have this condition, and the way they're picked up is either through vision screening or the teachers notice behavioral changes, the way in which they look at people. So I came across children who have been unfortunately been told off because they weren't looking at the teachers in their face, and that's only because they couldn't see looking straight ahead, so they have to look over to the shoulder, right or left shoulder, to be able to see objects, and they have a dystrophy, a cone dystrophy, and that's recognized through that behavioral change. As the child matures, there are individuals who present in their 20s or 30s, and they realize, when they drive, they can no longer see clearly, or the colors changing, or that the night vision is getting harder and harder to navigate at night time. So they get assessed by an ophthalmologist with various tests to identify that they have a rod disease or cone disease. And then there are also those who are only picked up because of screening. So, for example, I have patients who come to my room and I recognize that they have a condition, and I say, well, bring the whole family in because I want to see whether your siblings got it, whether your parents got it. And sometimes I find that their relatives will have the condition and not even know that they have any vision problem.
Does it always progress to blindness?
That's a very common question I get asked. Everybody wants to know whether they'll end up blind, and the answer is actually it's very rare to become completely blind. This is based on the experience in London when we tried to recruit patients for Argus 2 retinal prosthesis implant, and one of the criteria is to have no vision whatsoever, so no perception of light. And we struggled. We went all over the country looking for patients who are completely blind due to RP, and we just couldn't find many of them at all. So the worst case scenario situation of RP is that the peripheral vision constricts down to a very small island of vision in the center, and sometimes people can still read down to the bottom line of the chart despite that. Once that deteriorates to a certain extent, most people will maintain some kind of hand motion perception or counting fingers, so you can see big objects in the bright daylight, but not in the dark. Whereas people with macular dystrophy, cone dystrophy, where the central retina is affected, their side vision, peripheral vision, or night vision tend to be maintained throughout life. Now the progression is very slow, so one of the challenges for us is actually to monitor these changes over their lifetime. And that's a real problem for us in terms of working out what's the best way to monitor natural history and how to monitor response to treatment, if there is any.
Are there any factors that can accelerate the deterioration of someone's vision?
In the inherited dystrophy group, we are not aware of any external factors, except in the past there was studies looking at vitamin A supplementation, and there was concern that vitamin A may be detrimental to certain forms of inherited dystrophy. And so therefore we now do not recommend any specific vitamin supplementation. But aside from that, there's obviously smoking, which is bad for any kind of retinal disease. And my recommendation for patients with this is really just to live a healthy lifestyle and have healthy dietary intake.
So for someone who suspects he or she may be carrying one of these conditions, is early intervention any form of consolation, or does it offer any sort of prevention?
I think the key for any individual who might have inherited disease is to see someone who can establish a diagnosis. And the reason for that is because a lot of treatments are now being developed, and they are based specifically on the genes that's affecting them. Now, this process of establishing which gene can cause the disease is not like a simple blood test where you get the blood drawn, you have the result in a week. It's a long, drawn-out process which can last 6 months, 12 months, sometimes several years to identify the cause. And so the process needs to start early because it's a long process. But also being in a program where you can be monitored is also helpful, because once a treatment becomes available, it's useful to know what the natural progression rate is. And so that when the treatment is administered, we can then measure whether it's actually working or not.
Do you have a sense of the numbers that we're talking about in terms of patient presenting with inherited retinal dystrophy in WA specifically?
Yeah, so the population prevalence is about 1 in 3 to 4,000. And I suspect it's actually more common than that. So in WA, we probably have about 900 to 1,000 individuals with inherited retinal disease.
I see. And how does that stack up against the international numbers? Do we have a sense of where we are on the report card?
The prevalence is pretty much the same across all countries.
Now, you're involved in quite extensive research. When did you begin involving and participating in this research? And is it confined to Australia, or is there collaboration across the borders?
Yeah, so my research program started when I first came back to Perth in 2010, and I set up 3 streams of research from 2011. The first one was to set up a service so that we can diagnose and monitor patients with inherited retinal disease. This is a challenge because the conventional way we monitor disease is through a color photograph of the retina, and subtle changes in the retina cannot be picked up by simple color photograph. So there are many different modalities of imaging now we use to monitor changes, which can look into the number of cells that are remaining in the retina. The second stream of research is looking into understanding more deeply the mechanisms in which genes causes disease, and that's done through sampling the skin cells of patients with retinal dystrophy, and then grow these cells through various techniques into retinal cells so that we can study their retina without taking their retina. So just simply using the skin cells to model their disease.
So we're talking about adult stem cells and propagating those cells?
We're talking about adult differentiated cells. So these are fully differentiated skin cells, fibroblasts, which can then be turned back in time into a pluripotent stem cell, which then can be turned into a retinal cell or any other cells that we wanted to, really.
Right.
So that's a method for us to study disease and test drugs and therapies. And then the third stream is looking at therapies. So our third stream of research is translational, looking at testing cell therapy as well as setting up clinical trials in case new therapies arrived for these patients.
Now, in some of the work that I've read, or some of the literature that I've read about your work, there was something called IEPC. What exactly is that?
iPSC is a special type of cell that's derived from adult mature cells. Back in 2007, scientists discovered a method to turn fully mature differentiated cell back into totally immature undifferentiated stem cell, which is quite incredible, because we used to think that once a cell differentiates and becomes fully mature, it can never go back to become pluripotent.
Right.
So these pluripotent cells has the potential to become any cells in the body again. And one of those cells could be retinal cone cells or rod cells or bipolar cells in the retina. Our laboratory has worked on these cells, making heart cells, making neuronal cells as well as retinal cells.
What sort of findings are coming out, and what sort of results are being yielded from the work that you're participating in right now?
So our current research program is still developing and optimize the growth condition for these cells to become retina. And we have been successful in getting small grants in developing this further and testing new strategies in treating diseases like this. It's still early days yet, but we are not the only group. There are many other groups who are doing similar thing. Mm-hmm. If you imagine you need several groups for each gene, and there are 300 genes and thousands of mutations, there's a lot of work to be done in this area.
Common complaints with retinal dystrophy, just in layman's terms,
When I see patients presenting with retinal dystrophy, oftentimes they have already seen other doctors. And the most common story I hear is that nothing could have been offered to them, and they didn't see any point seeing more doctors because every other doctor they've seen has given up. But my approach really is that there are new advances being made, and therefore we should not give up. And so we should persist in identifying the cause to start with, and still take an active interest in how the disease is progressing, even if we don't have any treatments at this stage.
Right.
So that kind of complaints really about the overall care and how they're managed. But in terms of their specific symptoms, it depends on the kind of disease. So it could be a macular dystrophy, cone dystrophy, where central vision is poor, and especially cone dystrophy patients will have they are very sensitive to light, and some individuals cannot see small things in detail. They will need things magnified. Reading is a big problem because there are blind spots in their vision they can't get around, and therefore subsequently it's very difficult and frustrating for them to read. In contrast, people with retinitis pigmentosa, or we call them road cone dystrophy now, their main issue is bumping into things on the side, not being able to see things coming from the side, and night vision is absent. Steps are very dangerous for them because they don't see the next one down, and they can fall over steps very easily. And also they can be light sensitive towards the end later stage. In people who are very severely affected, where central vision is completely gone, or in retinitis pigmentosa where there's no central vision left and just have motion vision, some people will complain about hallucination, and this is called Charles Bonnet syndrome, and that's quite well established as a phenomenon in people who are suffering from vision loss, and their brain is desperately trying to fill the gap in their vision with images, often a pattern, a colorful pattern, could be objects, animals, or people they actually see, in the absence of any psychiatric or neurological disease.
And how often does that occur with people suffering retinal dystrophy?
It depends on the level of vision loss. So there are studies that showed up to 20% of people with severe vision loss may experience these kind of symptoms.
Now, one of the things that piqued my interest was the statement that we're looking for preventative measures, we're looking for treatment, and we're looking for cures. How does that all sort of play together with the work that you're doing? Does it make a difference if you're working towards prevention versus working towards cures?
I think the approach to eliminate blindness from this group of disease has to be manifold. So by identifying the gene, we will help couples who carries the mutation or have the mutation in a dominant setting in looking at preconception diagnosis. That may have an impact on the number of individuals born with dominant disease. Mm-hmm. So these are ones that pass down from one generation to another.
Right.
Now, in terms of prevention, earlier in the lifetime of an individual, let's say somebody who is born normal-sighted, but gradually losing vision over 30, 40 years, gene therapy is one of those approaches where it can modify how the gene is expressed, or even replace the defective gene with the virus carrying the normal gene to prevent further degeneration of the retina. So that's already in clinical trial. And then those individuals who already got established cell loss, we are also looking at ways of replacing cells in the retina using cell transplantation. Then there are also those who have lost a significant amount of vision where replacement won't work. Gene therapy will definitely not work. They may benefit from things like bionic eye or retinal prosthesis. So, there are work being done for every single stage of the disease process to try and counteract the problem that we're facing.
How do you compare the work that you're undertaking now with other schools of thought directed towards the same end?
Well, our approach through those three streams of research is very similar to many other groups. Most of the work that have been done overseas will focus on diagnosing disease, understanding mechanism, as well as looking at regeneration, replacement, and bionic vision. I guess the difference between what we're doing and many other groups is doing is that we're trying to combine all these aspects under the same umbrella.
I see.
And that could be said to be too ambitious, but I think without having all these avenues running at the same time, we may lose track of what's most important for the patients.
So you're looking for a synthesis of all the different areas that show some measure of potential.
Yes.
If you've just joined us, we're speaking to Professor Fred Chen of the Lions Eye Institute and Renee Loftus of Retina Australia, WA. And we're coming to you from our studios in Perth, Western Australia. This is Vision Australia Radio Perth. Talk to us about the bionic eye. I mean, it was, when I first came across it, I was bowled over, very excited. And of course, I thought about my schoolboy years when I watched, programs like The Bionic Man. I was wondering, I could probably see 5 kilometers ahead and, have X-ray vision and everything else. And that sort of vaporized very quickly when I found out what it was and what it wasn't. But tell us a little bit about the bionic eye, where we are with it and what it is and what it's not.
Okay. There are several brands out there. The one that's approved by the FDA in the States and EMEA in Europe is called Argus 2 implants. But there are a couple of them being developed in Australia. One of them is in Melbourne, and that's also placed inside the eye. It's a electronic device that's placed on the retina or behind the retina, which sends electrical activity into the retinal cells, which then get converted into signals in the nerve cells and sent to the brain. In the operation that we insert the bionic eye, we have to do a cataract extraction. We remove the lens, we take away the vitreous in the eye, we place this device around the whole eyeball, which has several components to it. One is a transmitter that sends and receives signals. The other one is a electrode array that goes onto the retina, and there are 64 electrodes on this array. And it gets tacked into the retina, so it doesn't move around inside the eye. Once the operation's finished, which takes about 4 to 5 hours, the patient then wears a special spectacle, which can wirelessly communicate with the device on the eye. There's a video recorder on the glasses that they wear, which capture the image in the outside world. That sends a signal via the wireless device into the electrode array, which then stimulates the retina. And this is a complicated setup.
Oh, it sounds like it, yes.
And it requires a lot of training. So these individuals who were treated or received this device had to come for weekly training of how to use the device for several months and up to a year, really. They're given certain shapes or flashes, lights that are traveling from left to right, up and down, certain shapes of light, and they have to recognize it. They get told what it is so they can recognize it. After a few sessions, then they get shown big letters and objects, and they have to move their head up and down and side to side to scan these objects. So for an individual who has not seen a letter H for 20 years, they'll recognize this letter by scanning the object up and down and see one flash, and side to side see 2 flashes, then they recognize it could be a letter H. So they learn how to recognize these patterns of flashes as a letter. So the vision they get is very crude. In fact, they don't get pixelated vision as we do. They get flashes of vision, which they have to recognize the pattern.
I see
what it is. There are obviously better devices now. So this one is only 64 electrode. It can recognize motions, but not pixel of images. There are devices now with over 1,000 electrodes in there, and it's placed under the retina. So potentially, if that works in generating pixelated pictures, then people can actually see images. But the results of these devices have not been released yet, so we don't know how the potential, how good this could be.
So is there a timeline where we can anticipate some breakthroughs for the people who are suffering retinal dystrophy?
There's breakthrough happening all the time, and these may not translate into actual treatment. A lot of these breakthroughs occurs in laboratories, in clinics, where they discover things like new molecules, new pathways, new ways of monitoring or imaging the eye. But to come to fruition of an actual treatment takes many years. Take for example age-related macular degeneration treatment. That drug has taken decades to get to the market. With retinal dystrophy, the disease is so heterogeneous. We need to look at every single gene and look at individual mutations. So it's very hard to predict what timeline we're looking at. A big factor in determining timeline is also funding. Research funding has to be available for this kind of work to carry through. Large pharmaceutical companies can fund long durations of studies, whereas groups like ours and many others relies on intermittent fundings, periods of 2 to 3 years. And if there's no ongoing funding, our program has to stop. And so it's very difficult from that perspective to really know, what we're looking at.
Right.
And I'm hoping in the next 5 to 10 years there will be something to offer.
So am I. Realistically, from where you sit and what you see and what you do with the clients and your research and all the investigations that you're conducting, do you think there will come a time where blindness can be eliminated?
I think so. From inherited retinal dystrophy, yes, because there are good data from early phase gene therapy trial to show benefit in cell rescue. And with collaborative work among scientists around the world and clinicians, I think this is possible in the very near future.
And are we talking about reversible treatment as well, as opposed to just prevention?
Correct. So there are techniques now to eliminate the mutation inside the cell so that the cell will function normally again. So this is a very exciting area where you can actually cure the mutation.
My final question, Professor Chen, are there barriers apart from funding that would stand in the way between a person regaining vision to some extent, given the fact that the breakthrough has provided treatment possibilities?
In accessing treatment,
yes.
Initially it will be clinical trials that patient will be participating in. So recruiting patients will be a barrier because there are many affected individuals who may not be aware of clinical trials being available. Right now there isn't any in Perth. There may be some in other countries. But being in contact with the retinal specialists who's interested in these kind of diseases will be a good start so that they don't miss out on being a participant in this trial. Other barriers will be distance, because to be in the trial you really virtually need to be very close to the trial site.
Close proximity to where it's happening.
So if you're in Kununurra or out remote area, it will be very difficult, because while we're conducting trial, we like to see these participants once every month or every 2 months to really monitor their progress, and over for a long period of time, perhaps even 1 or 2 years. That becomes an issue later on once we start to offer clinical trials. The other barrier will be financial, I suspect, because these treatments will not be cheap. However, if people are participating in a trial, a clinical trial, they will not be expected to have to pay anything. Right. So it's only when it becomes commercialized that could become a barrier.
So that's a wonderful lead-in to what I'm going to ask you, Renee. What's Retinal Australia WA all about?
So Retina Australia WA, our primary goal and focus is to raise funds for research. We don't do the research ourselves. We fund Professor Chen's research and other projects around Australia. We also fund the Inherited Retinal Disease Register located at Sir Charles Gairdner Hospital here in Perth. A register that is very important with the pending options of clinical gene therapy trials coming into WA or Australia even. So we continue to fund that. So yeah, that's our primary focus, is the funding of research, but then we also have a secondary focus of facilitating support for individuals who are affected and their families. We don't do the support ourselves. We do run monthly meetups so people can just meet up and have a chat about, you know, their life experiences, joke about walking into the gents at the pub last week when they should have been going into the ladies, that sort of thing. You know, one
That's
of those.
the humorous side of the dystrophy.
And it's nice to share some stories to realise that, you know, you're not alone and other people are dealing with some of the same challenges as you may be.
Yeah. What was the impetus behind Retina Australia?
So Retina Australia, which was actually in WA formerly known as the West Australian Retinitis Pigmentosa Foundation, actually started in 1978, so 38 years ago, by Dr. Arnold Cook, who many West Australian individuals who are affected by blindness or vision impairment may know of Dr. Cook. He was one of the first individuals to bring guide dogs into Australia back in the late 70s. So he had spent several years over in the UK where he was exposed to Retina International, or what is now called Retina International, what was similar in the United States in the early 70s. And so he decided to get a group of people together and start support groups as well as research funding.
So it was a private initiative at the very beginning.
Absolutely.
That really is fantastic. Now, you provide funding and you provide really one of the most important resources for this research to move forward. What sort of criteria do you have in evaluating one project over another?
Okay, so at a national level, so we fund some projects here just locally, but we also inject funds into Retina Australia National. And annually, that particular funding pool, which is contributed to from various states around Australia that have Retina Australia offices, that funding pool, or the grants that get funded from that, are actually assessed by our Grants Advisory Committee, which is made up of a selection of ophthalmologists, scientists, researchers.
You said that there was another function under REWA, and that's facilitation. Is the word support group anything relevant to what you're talking about?
Yeah, so we do run support group meetups, as I said, monthly. In my experience, having been with the organisation for over 3 years now, the people that I talk to, one thing that is a challenge for them is isolation, because it can be difficult to navigate leaving the house. And if you've had a couple of scares, it doesn't encourage you to keep trying. So being able to connect people with each other, we've got a list of members who are happy to receive phone calls to support their peers and just talk through the challenges. So that sort of support is really important.
It seems like a very broad spectrum of activities, even at Retina Australia WA. Where do you get your funding from?
There's several different avenues. We do quite a bit of tin collections through shopping centres, and you probably or may have encountered our tins on counters in supermarkets and delis and so forth around the city. Mm-hmm. We also run some annual events. We have an annual Family Fun Day down at Castlederm Miniature Railway. We do a couple of antique and collectors fairs every year. We have ad hoc quiz nights and gala dinners and bits and pieces as well. We also run an end of financial year and a Christmas donation appeal every year, and then bequests, leaving a legacy in a will.
From what you're telling me, it seems that there's a heavier reliance on community sources for funding. Does it preclude institutional sponsorship? It
doesn't. Typically, researchers such as Fred and the team at Lions would go direct to those sources. So we don't typically go down that channel.
Right, okay. So your main channels is pretty much within the community itself.
Definitely, yeah.
Okay. Now, we're talking about resources. We're talking about, the dollar sign. But apart from the dollar signs, what sort of other commitments and sponsorship, if you will, does REWA seek from the community at large?
A massive one for us is volunteers. As I mentioned, we do run a few events every year, so volunteers to help us pull those events off is very, very important. Our management committee, well, as you said, it was driven back 38 years ago by private individuals wanting to see a difference. So, our management committee is 100% made up of volunteers. And as I said, the events are a very important cash flow for us. So having people that can assist us to pull those off and grow them, and inviting their friends and talking about it within their community group is very important.
Renee, from where you stand, if you were to give anyone a piece of advice, particularly from your interaction with them through the support groups, what would you say to someone who's not quite sure whether or not they are feeling positive or able to deal with the fact that they are now dealing with retinal dystrophy?
I would absolutely recommend talking to someone, whether it is a counsellor or a psychologist, psychiatrist, a peer who is, as I said, often dealing with some of the same challenges as you. In a lot of cases, being made aware to an individual that they're not the only one that has had a similar experience can be refreshing, can be a weight off their shoulders. They don't feel like they're isolated anymore.
Feeling alone is terrible, isn't it?
Yeah, very, very. And I am in absolute awe of some of our members who are in fact affected by a dystrophy called Usher syndrome, which not only steals your eyesight, it robs you of your hearing as well. So
that's a double whammy, isn't it? Renee, where do our listeners go if they want to find out about the work that Retina Australia WA does and that is relevant to Professor Fred Chen's research?
Well, they can always contact me in the office, either via email, which is info@rawa.com.au, so that's info@rawa.com.au. Our website is also a reasonably good resource of information of the diseases and support available out in the community, as well as I always recommend to contact Lions Eye Institute for further clinical information with regards to your diagnosis, or if you're chasing more clinical information about the progression of your disease.
So, Professor Chen, I need to bring you back into the foreground. From your vantage point, you have a patient coming in and you know the person's going down that track with retinal dystrophy. What would you say to someone sitting down in your office when you're quite sure that the diagnosis is pointing that way?
The diagnosis of retinal dystrophy is very difficult to make, and so I would like to be absolutely sure that they have the condition by gathering as much information as possible. Once the diagnosis is confirmed, let's say we have the genetic results, I would then do my best to understand what the disease does, because every single gene mutation will have a different outcome. There are certain genetic mutations which may not cause blindness. Therefore, I can then confidently reassure the individual that they will not lose their vision. There are certain genetic changes that may lead to very slow progressive vision loss over several decades, and then I'll reassure that I'll be behind them all the way through this journey and try and find a treatment for them. There are also people who will come to me with very advanced vision loss already, just been diagnosed with this condition. So in those situations, I would then advise that we are now looking at different ways of restoring retina, and we have laboratories set up to do that. We have collaborators looking at bionic eye implants and bionic vision, and I'll keep them up to date from time to time, really not deserting them from the medical advances that are happening so rapidly.
So there we have it. I think that is a ray of hope for individuals and for their families who are suffering from retinal dystrophy. We've been speaking with Professor Fred Chen from the Lions Eye Institute right here in Perth, Western Australia, and with Renee Loftus from Retina Australia, WA. I want to thank you both for coming in. I want to thank you both for filling in the gaps. There's been so much discussed within social circles, but so many misconceptions, so many gaps in terms of understanding. Thank you so much for being here to the both of you.
Thank you very much.
Thank you.
Till we speak again next week, this is Kenneth Hua signing out.